Assalamualaikum Prof.
Waalaikumsalam.
Apa
Belum
kabar?
masuk lagi kan? Saya
Mhm.
mau boleh saya try slide?
Oh boleh Prof.
Mulanya pukul 10 kan?
Ya Prof.
Nanti saya cubakan dulu ya.
Baik Prof.
Assalamualaikum.
Waalaikumsalam.
Morning, Prof.
Good morning.
RK di Malaysia, Prof.
Apa ya?
Saya Dr. Yusa, Prof. Laring-laring, Prof.
Tidak nampak lah. Tidak nampak
Nggak
apanya?
nampak aja ya, Prof. Bentar ya, Prof.
Okey, nampak ya Arfiza?
Nampak Prof.
Jam berapa kita mulai, Ja?
Jam 9 waktu Medan, 10 waktu Malaysia.
Udah rame nih. Udah 41 nih, Ja.
Iya.
Sejak Senin kemarin, pemerintah Kota Medan mulai melakukan vaksinasi dosis ketiga atau booster yang serentak dilakukan di seluruh puskesmas yang ada di 21 kecamatan di Kota Medan, Sumatera Utara. Di mana sebelumnya Kota Medan terhalang vaksinasi dosis ketiga karena capaian vaksin terhadap lansia belum terpenuhi. Wali Kota Medan, Bobi Nasution, langsung meninjau pelaksanaan vaksinasi di puskesmas Provinsi Selayar 2 di Jalan Pemerintah Kota Medan.
Arfiza, suara saya jelas tak?
Jelas Prof.
Jelas. Saya nanti pakaikan headphone. Cuba diberitahu yang mana lebih jelas. Pakai komputer mic ataupun pakai headphone ya.
Oke baik Prof.
Vaksinasi booster dilaksanakan untuk lansia jenis vaksin yang berbeda dengan vaksin yang dilakukan untuk anak-anak 11 tahun. Dosis yang diambil ini.
Okey, yang mana lebih jelas?
Kayaknya sepertinya begini Prof.
Yang ini lebih jelas ya?
Ya.
Jadi saya pakai headphone lah.
Assalamualaikum, Prof Marina.
Waalaikumsalam, Dr. Andrina.
Ya, sehatkah?
Sihat, Alhamdulillah.
Alhamdulillah.
Ini pesertanya semua daripada Universiti Sumatera Utara ataupun daripada different university?
Sebahagian besar dari Universiti Sumatera Utara, Prof.
Okey.
Tapi ada beberapa juga dari sentra lain, dari institusi lainnya. Iya.
Okey, okey.
Assalamualaikum, Dr. Arfiza.
Waalaikumsalam Dr. Andrina.
Pesertanya yang ada di sini adalah pakar spesialis semua ya?
Ya, ya Prof.
Okey. Ada yang tengah training to become specialist?
Oh enggak Prof. Mohon maaf, semuanya rata-rata yang training untuk become specialist Prof.
Oh, ini postgraduate ya, yang training to become specialist. Okey. Kalau di sana trainingnya dipanggil apa ya?
Resident Prof. Atau PPDS.
Oh, okey, faham. Jadi kebanyakannya di sini berapa tahun residen di sana?
4 tahun Prof.
4 tahunnya. Kebanyakannya di sini tahun keberapa ataupun semua tahun ada di sini?
Semua tahun ada di sini, Prof.
Oh, okey. Jadi kita buatkan sesi ni macam interaksi ya.
Yep.
Sekiranya ada soalan boleh ditanyakan terus, boleh berhentikan saya kalau mau terus tanya soalan di slide yang tertentu. Kemudian saya juga mungkin bertanyakan soalan juga, terutamanya nanti bila perceptual evaluation tu mau ditanyakan persepsi suara ya bila didengarkan.
Baik,
Suara
Prof.
itu. Okay.
Recording in progress.
Boleh saya share slide ya?
Boleh, Prof.
Pukul berapa ya mau dimulakan tepat?
Nih, Prof, saya mau saya mau mulai nih, Prof.
Okey.
Biar nggak jomplang, saya pakai bahasa Inggris juga ya, Prof.
Ya boleh.
Oke. Sudah slide-nya, Prof?
Oh, sekejap ya. Mungkin kalau Arfiza mau mulakan dulu, boleh mulakan dulu. Kemudian bila saya mula kuliahnya baru saya share slide.
Baik, Prof. Okay, we begin our seminar. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Good morning, everyone. Today, welcome to our inviting Professor online seminar. This program was held by Otorhinolaryngology Head and Neck Department, Universitas of Sumatera Utara. Today, we have Prof. Marina Baki. Hello, Prof.
Oh.
Okay, she is a senior consultant, otorhinolaryngology head and neck surgery of Hospital Tunku Muhriz University Kebangsaan Malaysia. Subspecialized in laryngology. She was awarded her PhD in laryngology from University College London in November 2014. This morning, she will present about the anatomy of larynx and voice production, and also a basic protocol of voice assessment. This topic is very interesting for us for better understanding of voice and make precise diagnosis for our patient. I really wish that this lecture will benefit for all of us. If you have any question, please type it into the chat box. Prof. Marina, the time is yours.
Assalamualaikum warahmatullahi wabarakatuh. Very good morning to everyone. Here in Malaysia is 10 a.m. Over there is 9 a.m. right? First of all, I would like to thank Dr. Arfiza and specifically also to the University Sumatera Utara for inviting me for this series of lectures. And today, this morning would be the first lecture. So as Dr. Arfiza had mentioned, this is an important topic, and why we choose this topic as the first, because you need to understand this before we go on to deeper into laryngology topics. Then you would understand what are these measurements and what are we talking about when we talk about the voice outcome measures. Because certain surgical intervention in laryngology, it would be best if you measure the outcome. It is like someone who have hypertension, you measure the blood pressure and you give medications and you measure the blood pressure after that to look into the efficiency of the treatment, whether or not how good the treatment is in treating the condition. So with that, I would share my slide. So as Dr. Arfiza had mentioned as well, this would be, hopefully this would be an interactive session. You put in the chat box your question, and probably if I ask question, if anyone would like to answer, you may raise your hand and then you unmute your mic. Yeah. So this is the topic for today. About the anatomy and voice production would be a brief one, and the rest, the main, the gist of the lecture today would be on the basic protocol of voice assessment. This is, I'm going to change the slide. Okay, this is the complex of University Kebangsaan Malaysia Medical Center and Hospital Chancellor Tuanku Mukhris, which the hospital is over here. If you can see, you can see my cursor moving, right? So this is the Hospital Chancellor Tuanku Mukhris. You can see emergency department here, and over the left hand side, here the tall building here is the preclinical building, mainly for the preclinical science, basic science department. And we have the blue building over here, it's UMBI, the molecular biology unit for research. And in the middle here is the academic building. So this is the complex in Kuala Lumpur. So you're welcome to visit us. So this is the content of the lecture. First, I'm going to talk briefly on the anatomy of the larynx and voice production, followed by voice assessment. And we will go one by one to the types of voice assessment, the objective and subjective voice assessment, followed by conclusion. So this is the bird view of the larynx. You can see the cartilage, the thyroid cartilage. Above here is the hyoid, which is part of the laryngeal framework. And below here, you can see the cricoid cartilage, the posterior lamina. You can't see the anterior lamina. Maybe there's a shadow below here. And arytenoids, which are sitting on the shoulder of the posterior lamina of the cricoid cartilage. So these are the muscles, the main bulk of the muscles wrapping the laryngeal frameworks, adductor muscles, except this a pair of muscle at the back, which attach from the muscular process of the arytenoid to the posterior lamina of the cricoid. This is posterior cricoarytenoid muscle, which abduct the vocal folds for respiration. The PCA, the main function is to abduct the vocal fold and open the glottis for respiration. Other than that, the PCA also responsible in stabilizing the arytenoid on the shoulder of the cricoid cartilage, because without a function of this, the cricoid will easily prolapse into the airway. So that's why in cases of unilateral vocal cord palsy, you can see that the arytenoid prolapse into the airway because the posterior cricoarytenoid is flaccid and is not holding the arytenoid. Over here, you can see the thyroarytenoid muscle. Some people call it vocalis muscle. And at the back there, posterior end of the thyroarytenoid muscle is lateral cricoarytenoid muscle. So if you compare between the lateral cricoarytenoid and thyroarytenoid, the better adductor ADD is lateral cricoarytenoid. So hence, when you are injecting Botox, we are going to talk in other lectures about adductor spasmodic dysphonia. It would be best if you can target the injection to here at the lateral cricoarytenoid, okay? But if you inject the thyroarytenoid also it's not something faulty. It is correct too, but it is better if you can inject at the lateral cricoarytenoid muscle. And clinical applied, something I would like to say here is, if you have a tumor of the glottis, and if the tumor involve the paraglottic space, where it and involve the posterior part of the paraglottic space over here, laser surgery is not feasible anymore, because for laser surgery to reach the lateral cricoarytenoid muscle and clear the tumor over here is very difficult. So there's something that you need to remember. And other than that, over here, the most superficial intrinsic muscle is cricothyroid muscle. Okay, so the cricothyroid muscle is supplied by different nerve compared to other muscles. Yeah, other muscles of the intrinsic muscle of the larynx, the adductors and abductors, are supplied by the recurrent laryngeal nerve. The difference is the type of axon, in which the PCA is supplied by the abductor axon within the recurrent laryngeal nerve. Whereas the adductor muscles, the interarytenoid, thyroarytenoid, the lateral cricoarytenoid, is supplied by recurrent laryngeal nerve as well, but within it there are ADD axons, adductor axons. Okay, for the cricothyroid muscle, it is mainly supplied by the external branch of the superior laryngeal nerve, which is still a branch of the vagus nerve. So I move on to the next slide. Since we mentioned about the cricothyroid, here I show the cricothyroid. Okay, so the cricothyroid muscle is the most superficial intrinsic muscle of the larynx. Compared to others, you can't see from the outside. Yeah, it is all behind the thyroid cartilage. But the cricoid cartilage, you can see it from anteriorly below the strap muscles. So the cricoid cartilage attached from the cricoid to the thyroid cartilage. It is called cricothyroid muscle, and it has two types of fibers: straight fibers and oblique fibers. So how does this cricothyroid muscle control the larynx? It is responsible in lengthening the vocal fold, so the patient or we can produce high-pitched voice. Yeah, like from low pitch, and then if you want to go to high pitch, we have to contract the cricothyroid muscle. That is the effect of the exolaryngeal, like. So that is the cricothyroid. So the cricothyroid, if you can see the sagittal diagram, when the cricothyroid muscle contracts, it allows tilting of the cricoid cartilage. Because remember, there is a synovial joint, cricothyroid joint. So it allows tilting of the cricoid cartilage. So whenever the cricothyroid muscle is contracted, the cricoid cartilage tilt posterior inferiorly, and at the anterior part it goes anteriorly. So thus it brings the arytenoid that is sitting on the superior border of the posterior lamina of the cricoid posteriorly. Okay, I hope you understand this. Thus it lengthens the vocal cord. It lengthens the vocal ligament, and where attached to this is the thyroarytenoid muscle as well. Hence, the person's voice will be high pitch, will be in a glissando. Yeah. So the tilting of the cricoid cartilage due to contraction of the cricothyroid muscle will lengthen the vocal ligament, okay, or the vocal cord, and produce higher pitch voice. So how does voice is produced? Yeah, production of voice is complex. It is interaction between the respiration of the lungs, laryngeal framework or laryngeal structures, and a resonance system. All right, so now we're going to talk about what is the difference between voice and speech. So speech is a big component, voice is a small component of speech. The spoken word, or we call it speech, results from three components of voice production. We call it voice sounds, resonance, and articulation. So these three components form a meaningful word, a spoken word or speech. So what is voice sound? It is a basic sound produced by vibration of the vocal fold. So it's called voice sound. It produces buzzes, buzz sound, that is from vibration of the vocal fold. And resonance, when the buzz sound, vibration from the larynx, from the vocal fold, is brought upward and amplified and modified by resonators. What are the resonators? The throat, mouth cavity, and nasal passages. It produces a person's recognizable voice. So maybe over the phone, you don't see the person's face, but you can hear the resonance of the voice. You can identify, oh, this is Dr. Arfiza. Okay, this is Dr. Andrina. Okay, because of the amplification, the resonance. Someone may have like a hypernasal voice, that is the effect of the nose. Someone may have a hyponasal voice because of the nose is a bit blocked, a smaller nasal cavity, okay, and a high arch palate, and those form the resonance of the voice sound. So it becomes a person's unique recognizable voice. Okay. Then we talk about articulators. The articulation, the voice sound, which is amplified and modified by the resonators, and after that is molded by the articulation to produce meaningful sound, like and then you say, my name is Marina. So with the help of the lips, the tongue, the articulators, it forms recognizable words. So that form a speech. So so this is the basis of a voice and speech. Yeah, the voice sound, resonance, and articulation. Hence, for voice production, these are the organs involved. You need lung as a reservoir. It's a reservoir and produces energy to vibrate the vocal fold to produce voice sound, the buzzing sound. And then it is molded by the resonator and articulator to form a spoken word, recognizable speech, recognizable word, and recognizable person by, according to resonance of the voice. Okay, hence any issues within these organs may affect someone's speech or voice. Yeah. So there's a difference between problems with the articulation and problem with the vibration. So someone who have issues at the vibration level, we call it hoarseness. Someone who has scratchy voice, breathy voice, yeah, we call it hoarseness. But someone may have normal vocal folds, normal larynx, but the tongue is paralyzed. Maybe there's hypoglossal nerve involvement. So that's the voice, the speech becomes slurred. Like if I say my name is Marina, so whenever the tongue is affected, my voice becomes slurred. I would say my name is Marina. So the voice here produced normal. There's no hoarseness, but my articulation is problematic. It's called slurred speech, dysarthria. It's not called hoarseness, right? So, and then we want to know the basic of how the voice sound is produced. How does this mucosal wave and glottal cycle is produced? So whenever someone is talking, the first is the, of course, you have to have energy, reservoir in the lung, the air, and then the adductor muscles bring the vocal fold together in adducted position in the midline. So thus air from the lungs will be brought upward and fill up the subglottic pressure, the subglottic area. Thus increase the subglottic pressure. So as the subglottic pressure been built up here, it will slowly open up the glottis from inferior to superior. As you can see, it opened from bottom and then midline, and then thus it opened the whole glottis fully. So whenever the whole glottis is opened fully, there will be gush of air, or we call it puff of air through the glottis. When there is puff of air through the glottis, there is Bernoulli's effect. If you could remember what is Bernoulli's phenomenon, when there's a speed or air within a small column, regardless, it could be air, it could be anything else, but there's movement within a small column, there would be drop in pressure. So the faster the speed of the flow, the more drop of the pressure. So as the air column pass through here, so that would be a Bernoulli's effect, where eventually there will be drop in pressure and it will bring the vocal folds together because of drop of pressure. So it brings the vocal folds together, and the vocal fold will close from bottom and to superior again. Then the subglottic pressure will build up again because the vocal fold comes together. So the whole thing from opening, closure, opening and close again, it is called a glottal cycle. All right. So this glottal cycle, how many glottal cycles occur in a second determines someone's pitch of voice or frequency of voice. So Dr. Arfiza is a male. So he would, his glottal cycle probably 180 second, 180 hertz. So meaning he has 180 glottal cycle in 1 second. But myself, probably my hertz, my frequency of voice is 220. So I have 220 glottal cycle in 1 second. So the higher is the hertz, the more glottal cycle in 1 second, the higher is the pitch of the voice. Okay, hope you understand that. So then I want to depict the closure and the vocal folds now in adducted position. It's not in abducted, it is in adducted position. And you please observe the vibration of the mucosal wave, open, close, open, and it closes again. And also observe the lengthening of the vocal fold to increase the pitch of the voice. And you observe that during the lengthening of the vocal fold, the vibration becomes quicker. Hence the frequency of the voice is increased. There's more glottal cycle within 1 second occur. Okay, so you can hope you can appreciate the video. And this is a static frame to frame picture of a glottal cycle. Just now the video stroboscopy, there will be a separate lecture on video stroboscopy. You can see open, close, and close, open, and close again. And we take that into 10 frames. Of course, there are many missing frames here, but basically there is 10 frames from close phase, open phase briefly, and close phase again. A normal voice, the open phase shouldn't be long, shouldn't be dominating the whole analysis. Okay, this is a normal, and some people, they do have half closed and half open. That is also, in my experience, is acceptable. The voice is quite good. So now we move on to voice assessment. Let's see in the chat whether there are any questions. Okay, so there are no questions as yet. Please ask question if there's anything that you want me to repeat. You don't understand. Can I move on?
Maybe no question, Prof.
Okay, so I move on to voice assessment. So we have finished, that is just a brief one, a principle of the anatomy of the larynx, the intrinsic muscles, the nerve, and as well as the voice production. So hope that makes sense to you. Then we move on to voice assessment. So the voice assessment is a measurement of voice quality. So as I mentioned before, production of voice is complex. It involves interaction of the respiration, the larynx, and as well as the resonators. So therefore, it is recommended that the quality, the voice quality assessment to be multidimensional. So it can measure in different angles. For example, someone may have not so hoarse voice, but because of the profession, a professional voice user, maybe a teacher, when you measure the perception, you ask the perception, the patient would say, oh, my voice is really bad. But when you hear the voice, it's not too bad. Okay, and it doesn't mean that you don't have to treat the voice, because perception, and you see voice handicap index or whatever way you measure it, it is high. So it's something that you have to be concerned and you have to try to help the patient. So we're going to discuss on different types of voice quality assessment. So this measurements is important for treatment effect monitoring. If you don't have a voice quality assessment, how are you going to monitor the efficiency of your treatment? Whether it is voice therapy, whether it is medications, probably you give proton pump inhibitor, the patient have vocal fold edema because of that. We do some surgical intervention, and you want to know how good is your surgery, how good is your treatment. So it is very useful for treatment effect monitoring. For example, if you don't use this voice quality assessment, today you see the patient, you say the voice is hoarse, and then you treat the patient. 1 month later, the patient come back, you would say the voice is okay. And then 3 months later, you review again, the voice is better. But then whenever, let's say you have series of 10 patients whom you treat the same way, at the end you feel like, oh, I feel like I need to share this with the perhati THT, yeah, THT-KL, Telinga Hidung Tekak Kuala Lumpur Conference. I want to show that my result is good. But then how are you going to show the voice is okay, the voice is better? There is no specific measurement with which you can show what is the mean of the improvement, okay? So therefore, it is important for you to routinely do this voice quality measurement. And it is also very useful for communication between surgeons. For example, Dr. Lisa Aprianti, ya, itu daripada universiti mana ya Dr. Lisa itu, dia mau berhubung dengan Dr. Arfiza, refer case. Ya, dia mau beritahu how bad is the voice. She can say it in a giving the voice outcome. Oh, the voice is very hoarse, the overall dysphonia is this great, and the voice is really affecting her job, whereas hence the voice handicap index is this much. Okay, so it's easy for you to communicate when you are referring in the long distance. And with this voice quality assessment also, okay, would allow comparison between studies. Okay, let's say you want to do a trial, you want to do research, okay, you can compare between your results to other studies which been published in the literature. And you can gather of all studies, okay, for example, you want to see there's one treatment being proposed and many centers have used the treatment, and you want to see how good is the treatment. You want to compare between all the centers, so then you can do meta-analysis because we have these measurements. All right. So hence, in 2001, De Jonker had proposed. He's the first author. There's a list of authors here. In the European Laryngological Society, it was discussed there, and they produced this basic protocol, okay, for functional assessment of voice pathology. yeah, especially to investigate the efficiency, as I mentioned, and to also to evaluate if you innovate or introduce a new treatment for certain condition. So therefore, in this basic protocol for voice assessment, there list of what do you call that, outcome measures. Yeah, I'm going to mention one by one. In this basic protocol voice evaluation, number one is voice specific patient self-reporting outcome. So remember I said it is recommended to be multidimensional. There are subjective and objective measurement, and the subjective measurements, some are evaluated by patient themselves, some are evaluated by the surgeons themselves or speech therapists, and some are measured by machine, okay, which normally it is objective assessment. So the first one is voice specific patient self-reporting outcome. This is a subjective assessment. The patient rate themselves, how they perceive their voice, how much this voice problem affects the quality of life. So we call it voice specific patient self-reporting outcome. I mentioned here voice handicap index because this is what been used in our center at least, and many centers in Malaysia for now. The second one is also subjective evaluation, but this one is evaluated by yourself, by the professionals, by the doctors, the surgeons, or the voice therapists. Okay, it is called voice perceptual evaluation by professional raters, and there are many what do you call that, a skill that have been proposed. The one that widely used is called GRABAS scale, GRBAS. I'm going to talk more about this, and this is introduced by Hirano. The third one is an objective measurement. It is called aerodynamic analysis. This is to measure the subglottic pressure, glottal airflow, and there's way to measure this. And the cheapest way to measure, to do this analysis, is by doing maximum phonation time. The fourth one is also an objective measurement. It is called acoustic analysis. We're going to talk more about this after this. And the fifth one is videolaryngostroboscopy. So these are the voice evaluation that is recommended to be in your practice, in your daily practice. Yeah. Hence, or in any voice research for the purpose that I have mentioned in the previous slide. Now, we're going to go one by one. First is voice-specific self-reporting outcome. So, as I had mentioned, the voice-specific self-reporting outcome is a subjective measurement using a questionnaire according to how the patient perceives their voice. How does the voice affect the life and daily activities? So voice handicap index is not the only tool that is available in the literature. There are others questionnaire as well. They are called Vocal Performance Questionnaire, VPQ, Voice Symptom Scale, Voice. The one that widely used is Voice Handicap Index. There was a study by Cardick et al. In 2009. There are others which I'm not mentioned here. Cardick et al. Did a study, compare these three tools, the VHI-10, the VPQ, and Voice. And he found that all these three have excellent inter-rater reliability and have excellent internal consistency. Why Cardick et al. Did this research? This is because a questionnaire, a subjective questionnaire, have a weakness. Yeah? The weakness is on the reliability of the questionnaire. Okay, so probably today when I fill in the questionnaire, my score of voice today is 10/40. In 1 week time, when I do it again, I may do it, score it 20/40. So there's some variation. I forgot what I measure what I score a week ago. So there is some variation. So therefore, Carding et al. Wanted to know how reliable is this questionnaire? Can it be reproduced? Can we use it, and when we score it again and again, we get same result or at least very minimal variation? So they found that it is quite good internal consistency. It is quite reliable, from which is the efficiency or the comeback coefficient is 0.81 to 0.95, which is good. However, among all these three, voice handicap index reached the highest score, okay, the highest consistency, highest repeatability with intra-class correlation of 8.3. 0.83, right? However, voice handicap index 10, the original one, is quite laborious because it has 30 questionnaire. 30 questions, 30 items. So therefore, Rosen et al. In 2004 made an effort to shorten it. He had done factor analysis and he found that some questions are redundant, have quite a similar meaning. So therefore, he managed to shorten it into 10 with 3 domains. Functional item, there are 5. Physical items, there are 3, and emotional item, there are 2. And since then, this voice handicap index has been used widely in research, and you can see many literature voice research use this voice handicap index 10. So this is the English version, the original one, which is validated, developed and validated by Clark Rosen. When you want to use it in your country, in your population, there is an issue of cross-cultural adaptation, in which when you give it to the local population with different language, the person may understand it differently, yeah, because of the language, and because of the culture, it may sounds different. Okay, so therefore, it is recommended for the questionnaire to be translated to the local language, and you have to validate it, validate the reliability of the questionnaire. So for Malaysia, we have done, we have translated into Malay language. We call it Malay VHI 10, and it is already published in the Journal of Voice. You can check that out. And this is the question in Bahasa Malaysia. Now there are ongoing studies on the Malay voice handicap index 10 to determine the cutoff point. In the literature, so far there are 2 cutoff points being published. Number 1 is 11, another one is 7.5. What do I mean by cutoff point is when someone give marks to the questionnaire and you total it up. How much score of the question, which is over 40, the maximum score is 40, the bigger is the score, towards 40 is the worst is the patient voice, the worst is the voice affecting the daily life. Okay, so what is the score that is deemed as acceptable? What is the score that deemed as acceptable for the population? So that's why we want to find out whether in Malaysia we have the similar cutoff point with other countries or not. And there's another point which is not many people explore this. We call it minimally clinical important difference. It means that whenever someone score the voice handicap index 10, okay, let's say a patient who have unilateral vocal cord paralysis, you measure the voice is really bad, and patient score the voice handicap index 10 as 30/40. And then you did something, either you do voice therapy or you do surgical intervention. 1 month later, you ask the patient to score again. The patient score it as 20/40. So there's improvement by 10 score, reduction of score by 10, meaning we see that, oh, there is improvement of the voice, but we don't know whether that improvement of 10 score is something meaningful for the patient. Do this patient feel that, oh yes, I do feel better, This is something like, meaning a lot to me. Okay, I don't need any further intervention. So that is what we call minimal clinical important difference. I searched in the literature. I found that in Indonesia also, alhamdulillah, there is a translation into Bahasa Indonesia, Voice Handicap Index 30, which is the original one by Lisa Apriyanti. Dr. Lisa Apriyanti and Dr. Puspa Zuleika, Dr. Abla, and Dr. Adeline. So hence, so this voice-specific self-reporting is a trend now to be used in clinical trials because people deem that the voice-specific outcome would be the average or gather the voice performance as a whole. If you use objective measurement in the clinic, it would measure the patient voice at that particular time. So maybe on that day, the patient is in good mood. In the morning, have not used the voice as much, and when you measure, the voice sounds very good. But actually, when the patient went home in hectic life, the voice is different, and maybe the patient struggle with the voice. So therefore, this questionnaire measure the quality of life as a whole, daily life, how much the voice affect. So many clinical trials use this measurement instead of objective measurement. So then after this, we're going to discuss why do we still need the objective measurement. Okay. Because of the subjectivity, you need still objective measurement to support your findings. Okay, and normally you have to include that, yeah, in your report. Okay, now we're going to talk on perceptual voice evaluation. So just now we talked about patient perception. Patient fill in the questionnaire themselves, okay, and rate their own voice. Now, perceptual evaluation, patient come to the clinic, you assess the patient voice and you evaluate and you document how bad is the voice, okay? So this is done by professional raters. The scale that widely used is called GRABAS scale, GRBAS. I'm going to another slide. What is GRBAS? What I want to mention here is similar to voice. The voice related outcome just now. The patient self-reported outcome. This also subjective and it has its own weakness. Okay. Arfiza, when he listened to the patient voice, he may say that, oh, the voice is really breathy, moderately breathy. When Dr. Muhammad Husni saw that, listened to the patient voice, he may say, oh, it's very bad. I think this is grade 3. So there is variation in evaluating the voice. So if you want to use this in your research and you want to publish it, you have to archive the audio files. So at the end of it, you have to anonymize the audio files. You need to select raters. The raters do not know whose voice is that. And the raters wouldn't know whether the voice is recorded before or after treatment, and then give the score. That would overcome the confounding factors or bias in reporting your research. Okay, so what is GRBAS? G means overall voice quality, overall dysphonia. So this is marked as G. R for roughness or harshness of the voice. B is for breathiness. A for asthenia. S for strain. And for each, you have to give score from 0 to 3. 0 means normal. 1 means the voice is slightly deviated from normal. 2 means the voice is moderately deviated from normal. And 3, the voice is severely deviated from normal. Okay, so I hope you understand. So each item. So, and another thing that I want to mention is, because of this subjectivity and this issue of inter-rater reliability, again, Cardick et al. had done a research investigating the inter and inter-rater reliability, and he found that within these 5 items, the G, R, and B have the highest inter and intra-rater reliability, meaning when between one rater to another rater, there is very small variation and it is quite reproducible. So after this, I'm going to do some practice for you to listen to the patient's voice, and you try to evaluate what is the G, what is the R, and what is the B of the patient's voice. So what does hoarseness mean? The hoarseness means the voice is coarse and scratchy. It's like rock metal voice. Yeah? Normally, when the voice is coarse and scratchy, it may indicate that there is irregularity at the true edge of the vocal folds. For example, patient who have laryngitis, patient have lesion like polyp, hemorrhage or scar of the vocal folds. Okay. What about breathiness? When someone have breathy voice, it may indicate that there is excessive air escape during phonation, meaning there is no complete closure of the glottis during phonation. There is excessive air escape. Thus, the voice sounds breathy and sounds weak as well. That's what we call asthenia. For example, if I say like this, my voice is breathy and it is asthenic. It sounds very soft. Okay, there's no confidence, there's no projection of the voice. So examples of pathologies that affect the closure of phonation gap is vocal cord palsy, atrophy, big lesion impeding closure of the vocal folds, and cricoarytenoid joint fixation. Now I'm going to show some voice samples. Yeah. Now listen to this voice. This is a normal voice with G0, B0, R0, everything is 0. Okay, and these voices I collected when I did my PhD in the UK, in London.
When the sunlight strikes raindrops in the air, they act like a prism and form a rainbow. The rainbow is a division of white light into many beautiful colors. These take the shape of a long, round arch with its path high above and its two ends apparently beyond the horizon.
Okay, so that is example of a normal voice. Now I'm going to play for you a patient with unilateral vocal fold paralysis before intervention. And please appreciate that her voice is hoarse and breathy.
When the sunlight strikes raindrops in the air, they act like a prism and form a rainbow. The rainbow is a division of white light into many beautiful colours. These take the shape of a long round arch with its path high above and its two ends apparently beyond the horizon.
So you can hear the voice is breathy, and there's a hoarse as well. Okay, scratchy voice. So that's, in my opinion, the roughness score is 2, breathiness score is 2, and the overall dysphonia is 2. So something about GRBAS, the score of G would be the highest score of any of the items. For example, if I'm going to show after this, yeah, for you to understand. So G2, B2, R2. So the common principle that I use is if someone open the mouth and you straightly can hear the voice is hoarse, without you have to listen carefully, and it sounds so bad. So you would say this is grade 3, severe. When someone open the mouth, oh, this is normal. Normal is normal. But when you have doubts, you're not sure, is this normal or is it not normal? Maybe that is 1. It is mildly deviated, maybe sometime it sounds not normal. And whenever it is in between of severe and 1, we give it 2. Okay. This same patient 1, unilateral vocal paralysis after intervention.
When the sunlight strikes raindrops in the air, they act like a prism and form a rainbow. The rainbow is a division of white lights onto many beautiful colours. These take the shape of a long round arch with its path high above.
Okay, now can you hear the breathiness? Maybe some people can't hear, they would say B0. And perfectionists, some raters say, oh, there is some breathiness, and then they put it 1, breathiness 1, but definitely not 2. Yeah, it's not marked anymore. There's no more scratchy voice, so therefore the R is 0. The overall dysphonia is still 1 because you still have the maximum component over here, breathiness 1. Okay. Another example, unilateral vocal fold paralysis.
When the sunlight strikes raindrops in the air, they act like a prism and form a rainbow. The rainbow is a division of white light into many beautiful colors. These take the shape of a long round.
So you can hear that there is breathiness. Okay, there's no roughness, R0, and the overall dysphonia is 2. I didn't put here the strain and asthenia. If you want to put here the strain and asthenia, there is asthenia component. The voice sounds very soft. The patient can't project an asthenic voice. And this is the patient voice. So you to be able to differentiate what is normal and what is abnormal within the same patient.
Sunlight strikes raindrops in the air. They act like a prism and form a rainbow. The rainbow is a division of white light into many beautiful colors. These take the shape of a long round arc with its path high above.
So there's no breathiness, there's no roughness, but you can hear some resonance, hyperresonance, right? Hypernasality in patient's voice. So this is what we discussed just now. The resonance would make the voice a recognizable voice. So this, I remember this person, the name of the person, and so on. Okay, but for the vocal, the glottis component, there is no breathiness and you can't hear any roughness. Okay, another patient, unilateral vocal fold paralysis.
The rainbow passage. When the sunlight strikes raindrops in the air, they act like a prism and form a rainbow. The rainbow is a division of white light into many beautiful colors.
Okay, can you differentiate breathiness of grade 2 and breathiness of grade 3? Okay, the breathiness grade is really like, there's a lot of air escape, right? And therefore, the overall dysphonia also grade 3. The same patient had intervention.
When the sunlight strikes raindrops in the air, they act like a prism and form a rainbow. The rainbow is a division of white light into many beautiful colors.
Now you hear the voice is strained. This is because this patient had medialization, thyroplasty. It is too much of medialization. Now no more breathiness, no air escape, but there's strain component and there's roughness component. So the voice is still overall dysphonia is grade 3, but the items now different. You know, what contribute to 3 is the strain and roughness component. Okay, so I know that it's difficult for you to understand this and to be good at this within one session. So what I want to impart to you here is, after this, in the clinic, whenever any patients come with hoarseness, you try to do your GRABA scale for each patient. Practice doing it and keep on discussing with your friends, with your lecturers, if you have laryngologists over there, and then we polish up and improve our skill. I can see in the chat box there's some question. I would like to ask question about voices. Can we confident to video? Okay, this is not our topic. Maybe we can answer later. Yeah. So this is one perceptual voice evaluation. Okay, now I hope you understand this. Can I get a volunteer? I want to play a voice, and then you try to tell me what do you think of the the GRABA scale of the patient, GRBAS. Try, Nisa. Would you like to try?
Maybe the resident?
Yeah. Try, Nisa is resident, right?
Yeah, okay, right.
Okay.
Yes.
Okay. I play the voice, yeah?
Hello. Testing 1, 2, 3.
When the sunlight strikes raindrops in the air, they act like a prism and form a rainbow. A rainbow is a division of white light into many beautiful colors. These take the shape of a long round arch with its path high above and its two ends apparently beyond the horizon. 1, 2, 3, 4.
Okay, Dr. Trinisa, what do you
Yes.
think?
I think the breathiness is 3 and the roughness is 3 and for the G is also 3.
Okay, thank you. So let's see what I rated here. So I agree with you. I also put 3, overall dysphonia 3, roughness 3, but I think it's more of strain rather than breathiness. Okay, maybe there is some breathiness component, okay, but not marked. Yeah, it's more like scratchy, strained voice and scratchy voice. And from the history, this patient has fever, symptom of URTI, and acute hoarseness. Okay, what do you think? Someone who have this symptom, before you put your scope in, and this is the patient voice, what would be your differential diagnosis?
Maybe laryngitis.
Yes, right. Acute laryngitis. Very good. Yeah. So then you scope the patient. I'm going to show a video of a patient with acute laryngitis.
Hello.
Kita buat yang sebelah kanan kan?
Okay, so this is let me mute. Okay, so this is patient's larynx. Okay, we use video endoscope, and on close-up view, you can see that without stroboscope, there is some phonatory gap. Okay, this is not the same patient, different patient. Phonatory gap. And can you appreciate there is irregularity of the true edge of the vocal fold because of edema? Oops. Oh my God, I want to pause it, but it just wouldn't work. Never mind, let it moving. So hope you can see there's irregularity of the edge of the true chord. There's some inflammation and there is like a mucus on the true vocal folds. And when we turn on the stroboscopic light, appreciate the mucosal wave. So we're going to learn more about laryngostroboscopy in another lecture. So you can see that the mucosal wave not like the one that I've shown you before. Nice amplitude, symmetrical mucosal wave. Yeah, the amplitude is very small. So that contribute to the hoarseness. Okay. Case number 2. Can I get another volunteer? I saw here Dr. Aditya Pinam. Would you like to try? Are you a resident?
Yes, Professor.
Okay, I'm going to play the voice. Yeah, you listen to the voice.
Masa saya masih kecil, saya tinggal di kampung bersama nenek. Ayah dan emak tinggal di bandar. Abang dan adik saya tinggal di bandar bersama ayah dan emak. Setiap minggu, saya dan nenek pergi ke rumah ayah. Jika kami tidak ke bandar, ayah, emak, abang dan adik datang menziarahi kami di kampung.
What do you think?
Okay, I will try, Professor. I think the grade is maybe 1, and the roughness is 2, and the breathiness is 1, Professor.
So you think the roughness is 1, breathiness is 2?
The grade is 1, the roughness is 2, and the breathiness is 1.
Okay, so by right, the grade should be 2 because you have roughness 2, that is the maximum score. So you cannot have roughness 2, but your overall dysphonia is only mild. So it has to match. So it has to be grade G2, R2, and B1, is it?
Oh, yes, sir.
Okay,
Yes,
see. All right, so I grade this one as 3. Roughness 3, yes. U2, I3. So the inter-rater reliability still acceptable, not big variation. It would be a big variation if you grade as 2, but I grade as 0, normal. So that is very big variation. And there's some breathiness. Yeah, I agree with you. There is some breathiness component. Okay. And this patient, she doesn't have fever. He complained of hoarseness for months already, more than 6 months. His occupation is a receptionist. What do you think the differential diagnosis before you put the scope in?
Okay, Professor, maybe chronic laryngitis or vocal nodule.
Chronic laryngitis or vocal nodule. Any other differential?
I think I'll pass, Professor.
Okay, yeah, you hit it. Yeah, you get nodules. You may want to think about polyps as well, since the patient occupation is receptionist, maybe has been abusing her voice. Okay, and in this patient, the diagnosis was a cyst, and he had undergone endolaryngeal microsurgery and excision. Now, I want you to appreciate her normal voice. Compare with the abnormal voice that you have rated just now.
Semasa saya masih kecil, saya tinggal di kampung bersama nenek. Ayah dan emak tinggal di bandar. Abang dan adik saya tinggal di bandar bersama ayah dan emak. Setiap minggu saya dan nenek pergi ke rumah ayah.
Okay, so hope you can appreciate that. Thank you. Good try.
Thank you, Professor.
Here I'm going to show you a video of a patient with cyst, and then now I'm going to depict how does a cyst with irregular edge of the true vocal fold can have breathiness as well. Okay, look at this. And this is the stroboscope. You can see the mucosal wave is asymmetrical, and there is glottal gap, hourglass closure. Yeah. This is one glottal cycle. You can see that in one, remember about glottal cycle? Normal glottal cycle should be close, 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 open briefly, and close again, right? But in this patient, because of the cyst, it impede closure of the glottis. Thus, you see that there is always a gap. Okay, and it is the type is hourglass closure. There's only closure at the middle, but the posterior and anterior was open. Okay, that contribute to breathiness of the voice. Case number 3. Okay, now we know the diagnosis. Maybe we want to practice rating the grabas. Okay. Here I can see Zihazia Liumita. Are you a resident? Maybe she's not there. Kevin Pratama.
Yes, Prof.
Would you like to try?
Yeah.
Okay, I play the patient's voice, yeah?
Masa saya masih kecil, saya tinggal di kampung bersama nenek. Ayah dan emak tinggal di bandar. Abang dan adik saya tinggal di bandar bersama ayah dan emak.
Okay, what do you think of the patient's voice?
I think the G is 3, the breathing is 3, and the roughness is 2. I think 4.
So you think the breathiness component is more than roughness?
Yes, yes, Prof.
Okay, so you have G3, R2, B3.
Yes.
Okay, so let's see mine is 2. Because I think the voice is bad, but it's not too bad. Okay, so I put G2, R2, and the breathiness component is 1. Okay, so I think yours is 3, mine is 2. The inter-rater reliability is still acceptable. Okay, we agree that the roughness what the patient have. But I don't think the breathiness is the main component.
Setiap minggu saya dan nenek pergi ke rumah ayah. Jika kami tidak ke bandar, ayah...
You can hear the scratchiness is more. Then on and off, you can hear some air escape, yeah, breathiness component. So that's why I put the main component as roughness. This patient failed voice therapy. So after consultation and counseling, we said that we do surgery, but patient have to take care of her voice because it can recur. The nodules can recur. So that's we form surgery.
Masa saya masih kecil, saya tinggal di kampung bersama nenek. Ayah dan mak tinggal di bandar. Abang dan adik saya tinggal di bandar bersama ayah dan emak. Setiap minggu saya dan nenek pergi ke rumah ayah. Jika kami tidak ke bandar, ayah, emak, abang dan...
So hope you can appreciate within the same patient how just now we grade G2, R2, B1 with the voice, and now G0, R0. There's no breathiness, there's no scratchiness, and the overall dysphonia is 0, which is normal. Okay, and this is a picture of a nodule, bilateral. Okay, now we move on to aerodynamic analysis. Any question on this topic on perceptual voice evaluation? So we have voice outcome, patient perception, questionnaire, patient filling. Another one we learned just now, perceptual evaluation, you rate the patient voice and you document in the file. Then now we're going to talk about aerodynamic analysis. And within this, we're going to talk about maximum phonation time. So what is aerodynamic assessment? This assessment, the aim is to obtain information about vocal function by measuring the subglottal pressure and glottal airflow. Why is this important? Because this is a mechanism of the voice production. You still remember about the voice sound, how this what do you call that, Bernoulli's phenomenon, adduction, air from the lungs, Bernoulli's phenomenon, and the voice, the vocal cord close again, and how the glottis open because of building up of subglottal pressure below it. So by measuring this, it tells you the vocal function. How good is the vocal function, the glottis, in maintaining the subglottic pressure and allow just bit by bit of air, puff of air comes out. Okay. By the way, the voice is produced when there is gush of air. Every time there's puff of air, sound, buzzing sound is produced. Okay. And by doing this, it allows determination of measurement, yeah, pressure and flow through the vocal folds during phonation. So what are the measurements? Airflow rate and volume, subglottal pressure, laryngeal resistance, phonation threshold pressure. Okay, how can you measure this? You need an instrument. This is an elegant way of measuring the aerodynamic of the airflow in the vocal folds or in the glottis. So the person is wearing a mask tightly around the mouth, and then the person voice through the mask. And this machine would measure the subglottal pressure based on the air that been produced, the puff of air being produced each phonation. Okay, this is quite expensive, but if you have the money, buy it because it's very useful. What is the cheapest way of measuring, or cheapest way in reflecting the aerodynamic of the glottal airflow is by measuring the maximum phonation time. It measures the glottic efficiency. How good is the adduction of your vocal folds? How efficient is your vocal fold in maintaining the subglottic pressure and allow puff of air bit by bit until it can sustain a long duration of phonation. So typically, when you want to measure the maximum phonation time, typically you ask the patient, the person to say ah, and do it within one breath. So like if I breathe in and I say with comfortable voice, not shouting, not whispering, comfortable voice. you start the stopwatch and you measure how many seconds the person can sustain the voice within one breath. So it reflects the efficiency, the glottic efficiency. Someone who have glottic gap wouldn't be able to do long maximum phonation time. Let's say someone who have palsy, 3 seconds, because the air cannot be contained in the subglottic. Okay, it leak very fast, gush of air leak very fast, and it disappear quickly. And some people uses vowel E and U. So if you want, this is a recommended way of measuring glottic efficiency. Okay, but you have to standardize. You cannot like this particular patient, one visit before intervention, you tell the patient to say and then you measure, oh, this is 10 seconds maximum phonation time. You do treatment, 3 months later, you measure again, you tell the patient, please say ooh within one breath. That is wrong. Why? Because different vowel giving different cut-off point. If you try it yourself, you do R, you do E, and you do U, the duration of maximum phonation time will be different. And R is recommended because it reflects directly contribution of airflow from the glottis. Whereas E, you try to do E, there's a lips, tongue movement to the back, E, and someone would be able to say E a longer duration than R, okay, and similar to U. So you have to standardize. The recommended one is R, okay. And having said that, the maximum phonation time is useful and the cheapest, there are confounding factors. It is less accurate when the confounding factors are present in the patient. Like older age group may have a shorter maximum phonation time. Okay, those who have kyphosis, smaller lung volume, less energy from the lung would have shorter maximum phonation time, pregnancy, and so on. So hence, when you want to publish your result, you have to control these confounding factors. You have to exclude some patients, okay, if you want to report your results. In our center, we have studied this, okay. It is recommended for you to have your own population cutoff point or normative value for maximum phonation time, because different population may have different cutoff point because of our structure, our body build, our size of lungs, our craniofacial structure. Okay, maybe Indonesia and Malaysia similar. We are from the same region. We have similar structure. We have published this in Journal of Voice, waiting for the publication. It is available online. And here we come up with a cutoff point, yeah, for people who are, and then we compare between 3 different groups. We found that those who are obese, morbidly obese, have shorter maximum phonation time compared to normal people. And there is also significant difference, maximum phonation time between different vowels, between R, E, and U. Okay, so it would be good for you to do this in your center as well. Right, now we're going to move on. Another, in the basic protocol, another measurement, objective measurement, acoustic analysis. So we have aerodynamic measurement, that is objective measurement, measuring the aerodynamic fluid flow. Another one is acoustic analysis. What is acoustic analysis? Do we have any questions? So far, no questions. So I move on. Acoustic analysis. Right, next slide. It is a non-invasive, computer-based objective assessment of voice quality. So it measures the property of recorded voice signal. Okay, it measures where the voice is recorded in a quiet or sound treated room, and you run the audio file, the voice, in a software. Okay, in a software, and the software will measure the voice quality in terms of the pitch, the frequency of the voice, how many glottal cycle in 1 second. Okay, with what is the variation of pitch, We call it jitter. What is the variation of loudness of the voice? We call it shimmer. And what is the noise to harmonic ratio, NHR? So it objectively measure the voice quality using a software program. You need to record the voice and run the voice in a software program. I hope you understand this. So these are the common measures. There are lists of measurements, for acoustic analysis. This one that commonly used in voice research whenever like surgeons like us, clinicians like us want to publish our results. Number one is the fundamental frequency. What is the mean frequency of mucosal vibration? Okay, I mentioned about the frequency just now, F0. Jitter is a variation of the frequency. Okay, if you go into the pure tone audiometry room, there's a pure tone sound. You measure, you see whether the patient can hear at 250 hertz, 500 hertz, 1000 hertz, right? And when you turn on, you press the button for 250 hertz, the sound will come out at 250 hertz. Whenever you turn it on for 1 hour, it will be still 250 hertz because that is from a machine. But if a human produce sound, there would be some variation. You cannot sustain 250 hertz at 6 seconds, even at 1 second. Okay, there would be some variation. So therefore, there is acceptable normal range variation in frequency, jitter. So you look up in the literature, there would be normal variation for this. Shimmer, there will be is measurement of variation in amplitude. Amplitude is the loudness. Frequency is the pitch of the voice. And the other one is noise to harmonic ratio, looking at the ratio between the noise and harmony of the voice, which basically measure the degree of scratchy voice and the degree of hoarseness. Okay, we move on to the next slide. So there are many software programs. The widely used is multi-dimensional voice program. You have to buy it quite pricey. You have money, please do. And another one you can download from the internet. It is readily available, but you need a computer for you to download it. You need to standardize the microphone, okay, for you to record the voice and run the recorded voice into the software. It is called PRAT. If you look into literature, there are many papers on PRAT. And another one that being used in our center is OperaVox. It is a software program that been developed meant for Apple mobile gadgets. So let's say you have iPod, you have iPhone, you have iPad. You can download the software program from the Apple store and you can use it straight away using microphone of the mobile gadget. Unfortunately, the OperaVox software is now not available in Apple Store. But we are still using it because we have a few of our gadget with that software. So you still can do acoustic analysis using others. So this is example of robots that we have used. Maybe you want to develop in your own center, develop your own software program. That is the OperaVox. Install on an iPod, register first, then put the name, so on, and then you choose what you want to measure. Included in this is voice handicap index 10, the patient answer, and then the score will be documented in the software. And I forward this. Okay, now. That is maximum phonation time. Okay, hang on, I want to forward this. Okay. So whenever you're happy with it, what I want to show is, at the end of the measurement, you would see parameters. Okay, the software is analyzing the voice, analyzing what is the frequency, what is the jitter and shimmer, and it come out with a measurement. Okay, so that is the graph. And that is the measurement. It is too small for you to see. Okay, so hope you can appreciate. Yeah. So this is recorded voice. You save the audio file and then you run in a software, any software. There are many software in the market, in the literature. So the software will analyze the voice and measure the pitch, the frequency of the voice, the variation in pitch, whether it is normal or abnormal, the variation of amplitude, we call it shimmer, whether it's normal or abnormal, and what is noise to harmonic ratio. So for this, I have published a paper of Provox, and you can check it out on the clinical otorhinolaryngology. Over there, there is documentation on the normal range of each measurement. Okay, now the last one is video laryngeal stroboscopy. I'm not going to talk in detail about this because there would be a specific lecture on video laryngeal stroboscopy. So what is video laryngeal stroboscopy? It's basically an instrument that comprises laryngoscope. Either you use rigid or flexible. Of course, flexible have the advantage. The laryngoscope is connected to stroboscope and camera to record the examination. And this is important. You need microphone and pitch tracking. Okay. The reason being, the microphone will collect the patient's voice that is phonating and give it and transfer it to the stroboscope. Within the stroboscope, there is pitch tracking. Okay, and the pitch tracking will tell the stroboscope what is the pitch of the voice of the patient at that moment, and inform the stroboscope what is the frequency of flash of light that need to be emitted on the vocal folds. So probably it's difficult for me to show it here. There is another specific lecture. So the important point is this stroboscope is not just to look the mobility of the vocal fold. Open and abduction and adduction, that can be done with any laryngoscope. Okay, video laryngeal stroboscope is basically to assess the vibration, to assess the mucosal wave, to assess the closed phase and open phase and closed phase. Okay, whether the amplitude is normal, whether the mucosal wave is symmetrical, okay, whether there's any issues with that causing hoarseness, and that could help you in determining intervention and how to help the patient. So it is a vital assessment tool in the clinic. So this is the stack that we are using here by Pentex Medical. So here I want to show you a paper that published in 2018. What is the basic voice assessment, at least for unilateral vocal fold paralysis? We just now talk about basic protocol. You need to have a patient perception. What you perceive may be different what patient perceives. So you need to have patient perception, give a questionnaire, patient perceive their own voice. Number two, your perception. Okay, you document it. What do you think of the roughness? What do you think of the breathiness? Okay. Number three is the maximum phonation time that reflect the aerodynamic, the airflow, yeah, within the glottis. And you have money, you can buy more elegant tool to measure the aerodynamic flow. Number three is measurement of voice quality, the pitch and everything by using computer, by using a software. And number five is video laryngeal stroboscopy. Okay, yes, not many centers would have everything. Now, what is considered as basic? At least you have this in your daily clinical practice. Okay, number one is voice audio recordings. Yeah, if you don't have acoustic analysis, you still have to record the patient's voice. Use your phone, standardize it, you record the patient's voice every time the patient comes. Okay, because it has medical legal implication. The patient may claim many things, yeah, whenever they come. Say the doctor caused worsening of my voice. And you have the video, you can show that instead of worsening, the voice has been like this since before. Or actually the voice has improved a little with your intervention. It has not worsened. Okay, medical legal implication. And for you yourself, okay, to monitor the patient's voice. You forget the patient voice. The patient also forget her previous or his voice previously. I think last year I attended a conference by our Taiwan colleague, and they have invited Dr. Ishiki, who invented on the different type of thyroplasty, type 1, type 2, type 3, type 4 thyroplasty. So there was a patient with very bad voice for adductor spasmodic dysphonia, strangulated and very bad voice, couldn't talk, normal voice. And Dr. Ishiki did type 2 thyroplasty. The patient came back with a smoother voice, easier to talk, but she has a lot of complaints still. And what Dr. Ishiki said, you forgot your previous voice. You still have a lot of complaint. So that what I did in my clinic. The patient come and I asked, how's your voice? I can, wow, the voice sounds so good in my, in my opinion. Then just improve a little, the patient said. I go back to the date the patient saw me. I show this is your voice previously, and record the voice today and play it. And without me saying anything, the patient will say, wow, they actually improve a lot. They literally make a difference, okay? Psychology also make difference. So this is, you must do routinely voice audio recordings, yeah? It is indispensable prerequisite, okay? Next is voice handicap index 10. This is very important for you to do, okay, and easy. If you have not translated, just get from the internet first and translate it for the patient and make an effort to translate. But in Indonesia, you already have it. And another one is perceptual analysis. You don't need any instrument. Keep on practicing, do it routinely in your clinic. And acoustic analysis is optional. If you do it, it is even better and easier for you to publish your results. And you have more content to publish, to talk when you are, maybe Dr. Arfiza one day will invite Dr. Zuhdina Kamalia in giving a talk in her experience in managing certain patient with voice disorder. She can show her results. She can show the acoustic analysis before and after. So which give a plus point there. Okay, and don't forget maximum phonation time. Okay, so what is the basic voice audio recordings, voice handicap index, perceptual analysis, maximum phonation time, acoustic analysis is optional. Okay, maybe you don't have time to do in the clinic, you just record first. Later on, you have data, you can download PRAT from the, or you have money to buy MDVP. You can use the audio file and run it in the software, you get the acoustic analysis. Okay, do it routinely for before and after. So I want to depict you how easy you can get your work published if you have this measurement. Okay, even you don't have many patients, but you have content, you have evidence that it works, you still can publish it, although it does not involve many patients. And it would be a high chance for you to share your work in journals, okay? If you have this measurement, yeah? And you can do longitudinal data, okay? And for you to do this, you have to develop your own proforma in your clinic so that you standardize this. Anyone in the clinic who see this kind of patient or voice disorder would have to fill in the proforma, make sure everything is ticked and done. But the challenge is for you to get it done, collate it, and store it and analyze it. So that's another thing that you have to do. So by doing this, at the end of the day, maybe 1 year, 2 years, you have a big data to play around, and you can do a lot of research with it. This is an example of proforma hard copy that we have. Of course, with this proforma, you need to transfer it to Excel, make it a soft copy so that you wouldn't lose it. Okay, I show an example. We published this in a journal. What journal is this? Ear, Nose and Throat Journal on primary non-selective laryngeal re-innervation, case series and literature review. We have done about how many? 5, 6, but only 3 patients complete 12 months follow-up. We still can publish it because we have this all the measurement and we can show how much improvement of patient's voice in form of jitter, in form of shimmer, noise-to ratio, maximum phonation time, and so on. And we can show the graph. This is another example published in Journal of Voice, where at the end of the day, although you cannot do randomized control trial, you can compare 2 different groups, the re-innervation group and thyroplastic group, because we have all the measurements. Okay. All right. So in conclusion, voice and laryngeal evaluation is important for diagnosis, treatment selection, treatment effect monitoring, and it has to be multidimensional, not only subjective, you also have objective to support your subjective measurement. Video laryngeal stroboscope is important tool. We're going to talk about this in other lecture. This is a minimum voice assessment, voice recording, GRBAS, GRABAS, VHI-10, maximum phonation time. Acoustic analysis is optional, but from now, it would be good if you can keep on collecting the voice, the audio files, okay, of patient's voice, and maybe one day you can do the acoustic analysis when you, you manage to buy the instrument or software. And with that, thank you so much. That's the end of the lecture.
Thank you, Prof. A very informative lecture. Maybe from our department, it's not really complex like you show us in the lecture. Maybe next time we make better assessments for the voice quality. And is there any question maybe from the resident?
Oh, there is a question that I haven't answered. Yeah. Someone asked. I would like to ask a question about voice disorder. Can we confidently diagnose the etiology of voice disorder without laryngeal stroboscopy? Okay, so the answer is certain voice disorder, yes, you do not need video laryngeal stroboscopy to diagnose. For example, the unilateral vocal cord palsy. You don't need a stroboscope to diagnose that one vocal cord is immobile or palsy. You don't need a stroboscope to diagnose a big vocal cord cyst. Okay, stroboscope will be useful, especially in subtle lesion, small lesion, in patient who have hoarseness, but when you do endoscopy, you don't find what's wrong with the vocal cords. There's nothing wrong. The stroboscope is important. Yeah, there may be sulcus that you can't see. There may be small scar that you can't see. Okay, there may be intracaudal cyst which is not apparent. There may be small lesion which is not apparent. Big lesion, you don't need it. However, when you are doing intervention in those big lesions, stroboscopy is an important tool for someone is talking.
Wait, Prof, I will mute it. Maybe can.
But however, whenever you want to assess the outcome of your surgery, it would be good if you do video stroboscopy before and after. For example, you are excising a big vocal cord cyst like I've shown in the slide just now. One of the main complication, common complication of excising vocal cord cyst is vocal cord scar. Yeah, so you want to, if you do before the surgery, you can assess any non-vibrating segment, any pre-existing scar. So people wouldn't blame on your surgery causing vocal cord scar. Okay. Also, after the surgery, let's say the mucosal wave is good, and after surgery, you assess again, the voice is not perfect, and you can see the mucosal wave, and then you can see whether there's any vocal cord scar occur following the surgery. Okay, then you can inform the patient, oh, the cyst is no more there, but your voice is slightly hoarse because there is scar. Okay. That's important for the patient to take care of the vocal hygiene, take care of the voice after the surgery to minimize formation of vocal cord scar as well. Okay, another question.
Maybe there's a question, Prof, from the resident. Good morning, Prof and Doctor. I would like to ask about the Botox injection. Maybe this is another lecture, Prof, where the condition Botox injection indicated and we evaluated it. Maybe you don't need to answer this now because another lecture will be answer it, Prof.
Yeah.
Maybe we go to another next question. Good morning, Prof and Doctor. I would like to ask question. Can you explain about the correlation of maximum phonation time to the body mass index? Maybe the correlation, Prof.
Yeah, that's good question. Why body mass index affect the maximum phonation time? Yeah, we see a negative correlation. Negative correlation, meaning when the body mass index is increasing as the patient become more and more obese, the maximum phonation time become less and less. We call it negative correlation. If positive correlation means the body mass index increase, become more obese, maximum phonation time also increase. That is positive. So we're talking about negative correlation. Why? Because there are many theories behind it. One of the theories is with increased body mass index, means there's fat deposition in the abdomen, around the respiratory muscles. Hence, the energy, the lung reserve is less. Okay, the energy from the abdomen also less. So when you have less energy, it will affect the glottic efficiency as well. It will affect the energy. Okay, it will affect the duration that you can say because you have less volume from the lungs. Okay, so that is the theory. You may want to read more about it. Okay, there are many theories, and one of the theories is fat deposition, smaller lung reserve.
Okay, Prof. That's a good question. Okay. We go to the next question, which is also the buttocks injection. I don't know why they ask about the buttocks. Maybe the next time, Prof. We have a 12th session, so we will wait that answer for the next session. Okay. The next question is from Dr. Andrina. She like to ask about the factor can influence if someone produce discordant voice. What factor can influence if someone produce discordant voice, Prof?
That's a good question. Where is Dr. Andrina?
Dr. Andrina. Okay.
It will be good if you have interaction. Where is Dr. Andrina?
Yes.
Before I answer the question, probably Dr. Andrina also can give what you understand. Yeah, Dr. Andrina is not resident.
No. Dr. Andrina is the head of our department.
Oh, I'm so sorry. I thought a resident. So but my resident, when they ask question, I like them to answer first. Okay, never mind. So for Dr. Andrina, I answer. So for someone who have discordant voice, what are the factors? So when we talk about hoarseness, okay, anything that affect the mucosal wave would cause discordant voice or voice disorder. Okay, so what are the factors then can affect mucosal wave? If we go back to the body and cover theory by Hirano, the vocal folds, there are layers. The outmost layer is the epithelium mucosa. underneath it is superficial lamina propria, which is a loose area between the epithelium and deep on the vocal ligament, which the vocal ligament is formed by the intermediate and deep lamina propria. And deeper to the vocal ligament is muscle. So any issues affecting this layer, the epithelium, the superficial lamina propria, the vocal ligament, as well as the muscle, would affect the voice. For example, we go from most superficial to the deepest. The most superficial, the epithelium, any insult, any irregularity to the mucosa, okay, for example, lesions, nodule, polyp, cyst, any inflammation, edema, okay, tumor, okay, would cause hoarseness, right? And then we go to the vocal ligament. If there is scar, which cause adhesion of the superficial lamina propria and the epithelium to the vocal ligament, that would also cause hoarseness. All right. And a deeper part, muscle, if the muscle is weak, like someone who have vocal cord paralysis, that would cause flaccid vocal fold. Therefore, the mucosal wave wouldn't have a nice rigid floor for it to vibrate. So that would also affect the voice. So any problem with this layer can cause hoarseness. Of course, we always talk about hoarseness. There are two types, two big group that can cause hoarseness: functional voice disorder and the organic voice disorder. In functional voice disorder, we can't find any issues with the layers. Even we do stroboscopy, okay, we examine the vocal fold, nothing, but the voice is hoarse. So there's another topic, big topic, yeah, about functional voice disorder like pubophonia, like conversion voice disorder, primary muscle tension dysphonia, okay. But for the organic, the structural part, you can see the problem, okay, or neurological when there is vocal cord palsy. So these two can cause hoarseness. So I hope that answered the question.
Thank you, Prof, for the explanation. Thank you very much.
You're welcome.
Okay, we go to the next question, Prof. How to measure the grade, the voice perceptual evaluation, and what kind of sentence in Bahasa we can use for evaluate that, and how we use it for therapy. Thank you.
Okay, voice perceptual evaluation is professional raters. Okay, I mean you rate your voice, the patient's voice. So the question is how to measure grade. The measure grade is you yourself measure. It is subjective. And the tool that I proposed just now is the one introduced by Hirano. We call it GRBAS. Okay, and for each GRBAS, you have to give score from 0 to 3. This is to standardize the way you rate the patient's voice. Okay. Hence, you need to standardize the sentence. Okay. So in our center, we have two passages that we use routinely. If the patient is not well versed in Bahasa, okay, we tell the patient to read rainbow passage that you can search on the internet. It is originated from the America. The rainbow passage, when the sunlight strikes raindrops in the air, it acts as a prism and form a rainbow. The rainbow is a division of white light and That's a passage. You can find it on the internet. And in Bahasa is the one that you have been listening just now. Semasa saya masih kecil, saya saya tinggal di kampung bersama nenek, ayah dan emak. So we standardize. So it would be best if you develop your own local language, because when the person is comfortable with the language, the person can exhibit as normal voice as possible. Okay, like myself, I'm so comfortable with Bahasa Malaysia. Suddenly you ask me to talk in Indonesian accent. Apa khabar Pak? Nanti suaranya jadi lain. Yeah, and there would be some strain component muscle tension dysphonia occur because of anxiety. I'm not familiar with this accent, and yet you tell me to talk in this accent. So that would give strain component to my voice. So my voice wouldn't be as natural. Okay. So if you want to do the perceptual voice evaluation, you use a standardized passage. You can develop your own. Maybe you can speak and discuss with your speech therapist what would be a nice passage that would cover all vowels, all consonant, and different intonation. Okay. Some patients we do encounter they can't read. So we just tell them to say, tell their name, address, where they live, and say 1 to 10 within one breath. So that the minimum you can do if the patient can't read. Okay, hope that answered the question.
Thank you, Prof. Maybe this is related from the question before. Is there any question at the scale that can be used to evaluate the hoarseness other than Grabash scale from Hirano, Prof?
I think there is. It is called CAPE-V, C-A-P-E-V, CAPE-V. Okay, I write it on the chat. You can search on the internet. Yeah. CAPE. Yeah, CAPE-V.
Okay, thank you.
Maybe
Prof.
there are some more, but I'm not aware, not familiar with it.
Better we use the familiar one, right? Like the Grabash from Hirano, right, Prof? Okay, another question. The sentence spoken by the patient for voice perceptual evaluation. Should it be validated and specific sentence, or we can just use any sentence in any language used by the patient?
Okay, I don't think it has to be validated because it is just for you to standardize a passage so that that patient read the same passage again and again, and other patients the same passage. I'm not aware of validating a passage for the purpose of voice perceptual evaluation. I may search it, okay, find out whether it need to be validated, but for now, as far as validation is concerned, I don't think it is necessary.
Okay, thank you, Prof. Maybe we should standardize in Indonesia, perhaps. Okay. Next question: when the patient with the hoarseness symptoms come to our clinic, is that very necessary for us using the diagnostic test aerodynamic assessment rather than any other diagnostic tools, or this is just an adjuvant diagnosis test?
Okay, very good question, Inanda. I would say the one with specific tool that I've shown, the aerodynamic assessment is more of adjuvant, more for research. Okay, if you want to publish, you want to show results of your treatment. Okay, aerodynamic assessment that I found clinically applied and have clinical importance is maximum phonation time. Okay, because you can relate how breathy is the patient's voice, how struggle is the patient's voice to sustain the phonation. Okay, someone who have maximum phonation time of 10, you can know that the patient is not struggling the voice as much as patient who have maximum phonation time of 3, where every word the patient have to take a breath, another breath again. Okay, so yeah, I would say that the aerodynamic assessment is more of adjuvant, it's more for research and optional. It's not an important tool for day-to-day basis, but you have it, it would be good, and you collect your data, that would be good for a voice research.
Okay, thank you, Prof. Maybe another question is about he want to uh, uh, ask you about the more explanation about the asthenia and breathiness from the Grabash, Prof.
Okay. So asthenia is the voice is soft. Someone may not have breathiness, but the voice is just soft like this. Nama saya Marina. Saya tinggal di Kuala Lumpur. Okay, my voice is not that breathy, but it's asthenic. It's very soft. It's hard to hear. It's very soft. And it's no voice projection. While breathiness, there is, you can hear the leak, the air leak between the two vocal folds. Okay, and always, not to say always, most of the time, breathiness and asthenia come together. Because normally patients who have severe breathiness, there will be asthenic as well, difficult for them to project the voice. There is a small group of patients who do not have breathiness, just asthenic. There is no strength in the voice. For example, patient with Parkinson. Yeah, I've seen patient with Parkinson. There is good glottal closure, but there is no strength in the voice. The voice is so asthenic. Okay.
Okay, thank you, Prof. Is there any question?
So I hope that answer about the asthenia and breathiness. When you see more patients in the clinic, try to relate that. Yeah.
Thank you, Prof. Is there any question? Still, there's no question. The last question is still about the asthenia and the breathiness.
So Dr. Arfiza, after this, do you think you would be able to start doing the voice assessment in the clinic?
Yeah, actually, I want to I see you lecture before in the Malaysia about 2 years or 3 years ago. I want to use it also, but the one that I use only for the recording, voice recording, and the grabber scale, but about the Opera Fox that I told you before that I can download it from the
Apple Store.
Apple Store, because it's not available anymore, and I still want to find any software about it, but yes, we still try to it.
Yeah, you can try Prat if you have the recorded voice. Yeah, you download Prat and you try to play around with Prat. Prat.
Yeah. But the patient sometimes not really have many voice problem. They in our department still have the most cases is the cancer or obstructive sleep apnea, or the maybe the abscess of the head and neck. Still, the majority of our patients, the voice is not really routinely come to our outpatient clinic in our department.
Yeah, I found that the voice problems are underdiagnosed or underestimated, because many patients out there not realize that they have voice issues. I have talked to people like, you have some voice problem. Yeah, I do, but the person doesn't know where to go. So it would be good if you do from time to time some roadshow, some webinar for the public, for them to be aware about voice problems. And we do see patients come forward after they listen to our talks, because this is actually a voice problem, something that we can treat, for example.
And also in our department still have no speech and language pathologists, so sometimes it's very difficult for us to treat the patient that I asked you before, like the puberphonia. It's very difficult to find the speech and language that I just refer to the UKM for the speech and language pathologist, but the patient still never have a contact for me anymore after it. But the problem is still his. Our problem is there is no speech and language pathologist also. So
Okay.
so sometimes the patient with the focal nodule with just a voice therapy, but on for a few short duration, and then we use surgeries to treat it because no speech and language pathologists in our center.
Yeah,
Still.
we will cover on malignant cancer of the larynx in other lecture topics.
Maybe Prof, other topics maybe we can use maybe 15 question choice question for the resident for if for the evaluation if they're listening to our lecture or not.
Sure. Next time,
Yeah.
next time I'll do the question because it was short notice
Yeah.
yesterday, so I didn't have time to prepare the questions.
Okay. Is there any question? If no other question, maybe we can close this lecture. Maybe Dr. Andrina. Dr. Andrina.
Yes, Dr. Arfiza.
Yeah, maybe this is our last session of this seminar. Maybe Dr. Andrina can close the webinar for us.
Thank you, Dr. Arfiza. First of all, I want to thank very much to Prof. Marina for her kindness to give us many knowledge today and sharing her experience. So don't be jangan bosan ya, Prof. Marina, to teach us next time. So we prepare this lesson every month, if you don't mind, to give lecture for us. Thank you for all participants in this morning webinar. I hope this morning this webinar will give benefit for us in our daily activities. Thank you.
Thank you, Doctor. Thank you, Dr. Waalaikumsalam. Thank you, Dr. Andrina, for having me here. And I hope the lectures and our series of lectures in the future would benefit everyone. Thank you for inviting me. Okay, bosan tidak bosan. Cuma harapannya apa yang saya sampai ini menepati yang diperlukan.
Okay.
Then enough, Prof.
I'm happy with the feedback questions from the residents. Okay, more questions means they understand the lecture and they start thinking. So I'm happy. More questions is better.
Okay, but thank you, Prof. Assalamualaikum warahmatullahi wabarakatuh. Thank you, Dr. Andrina, also. Thank you for the for this for the lecture today. Yeah. Assalamualaikum warahmatullahi wabarakatuh.
Di sana weekend ya, Arfiza? Weekend ya?
Yeah, weekend.
Saturday. Have a nice weekend.
Have a nice weekend juga,
Thank you, Prof.
Assalamualaikum.
Waalaikumsalam warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi
Excuse me, Prof. Maybe we can take picture before.
Before we leave, Prof, can we take a photo?
Professor, doctors, and residents, I will take the first photo of the first slide in 3, 2, 1. Okay, and then for the second slide, you can open the camera now. Okay, 3, 2, 1. And for the third slide, 3, 2, 1. Okay, for the last slide. Okay,
Thank you very much, Prof and Doctors.
Terima kasih. Saya leave the webinar ya.
Ya, terima kasih Prof.
Thank you, Prof. Marina.
Hai, Assalamualaikum Dr. Noviati.
Iya,
Ada klinik ya hari ni?
lagi operation lah.
Ada operation lagi. Oh my. Ini kerja lebih ujung minggu.
Cari dulu lebih. Oke, thank you Dr. Marina.
Okay.
Recording stopped.
Thank you, Prof.
Okay.
Ini